Usually when we talk about a medical diagnosis, there's this expectation of precision.
Oh, absolutely.
Like, break your arm, the X-ray shows a jagged white line, and the doctor just points and says, there it is.
Right. Yeah. It's comforting. We really want illness to be visible and binary, like broken or not broken.
Exactly. But you step into the world of neurodevelopment and complex mental health, and, well, that X-ray machine just completely shatters.
It really does.
We are looking at a diagnostic landscape that is incredibly murky today. We're doing a deep dive into schizophrenia. And, the reason this matters to every single person listening to this is that this condition typically strikes during the late teens and 20s.
Yeah, the prime years for building a life.
Right. Yet a lot of what you, the public, probably believe about it is based on outdated manuals, media caricatures, and literally a translation error from over a century ago.
Yeah. Which is exactly why we need to unpack how this diagnosis evolved, right? Because the sources show it's not just a checklist of symptoms. It's this century-long struggle to define a really complex biological reality.
So we start the timeline in 1893 with Emil Kraepelin. He's a German psychiatrist, and he's looking at severe deteriorating mental illnesses. And he labels them dementia praecox, which means premature dementia.
And, Kraepelin did something revolutionary for his time with this. He didn't just take a snapshot of a patient on, like, a random Tuesday.
Right.
He actually tracked their illness over years, looking at the long-term trajectory.
So he was really playing the long game.
Exactly. And by doing that, he noticed this fork in the road around 1899. Some patients had this progressive cognitive decline starting in their youth, so that was his dementia praecox.
Okay.
But others had these episodic cycles where they actually recovered in between episodes.
And that second group became what we now know as bipolar disorder, right?
Yes. It's known as the Kraepelinian dichotomy, and it basically built the architecture for modern psychiatry.
But the term itself, dementia praecox, had a fatal flaw. It sort of implied this hopeless, inevitable downward spiral, like the brain is just going to dissolve, and that's the end of the story.
Right. And the clinical outcomes didn't actually support that extreme pessimism. Some patients didn't just continuously decline. So in 1908, a Swiss psychiatrist named Eugen Bleuler proposed a completely new framework.
Okay, here we go.
He combined the Greek words stetsein, which means to split, and phrin, meaning mind, schizophrenia.
And This right here is the translation error that has confused the public for over a century. The moment people hear split mind, they instantly picture someone with multiple, completely different identities living in one body.
Yeah, which is dissociative identity disorder.
Completely different.
A totally different condition, different causes, different presentations entirely.
Right. Bleuler was talking about something else entirely, and I was trying to visualize this from the sources we read. And it's not like an orchestra suddenly becoming a completely different orchestra.
Oh, I like that.
It's more like the string section and the woodwinds suddenly playing two entirely different songs at the exact same time. Like the individual parts are still there, but the harmony is just gone. Your emotions no longer match your ideas.
That orchestra analogy is perfect. It captures Bleuler's concept exactly, because he was describing a splitting within mental functions, like a loosening of the normal associative links in the brain.
Right.
He actually detailed this through what he called his 4 A's. So he sought loosened associations, where thoughts just don't cohere logically, then ambivalence, autism, and he meant withdrawing into an inner fantasy world, not the modern autism spectrum we know today.
Got it.
And finally, blunted affect, which is a flattened emotional expression.
But notice what's missing from that core list of his hallucinations. Hearing voices, delusions.
Yeah.
That is literally the entire focus of every thriller movie. But Bleuler barely centered them at all.
Well, he considered them secondary, or like accessory symptoms, which is wild when you compare it to how a doctor actually diagnoses the condition today.
Because the modern manuals, like the DSM-5 and the ICD-11, they've totally shifted the spotlight. They break symptoms down into positive, negative, and cognitive domains. And we really need to be clear here that positive and negative don't mean good and bad in this context.
Right, no. In a clinical sense, positive symptoms are things added on top of typical mental functioning. So hallucinations, fixed false beliefs, which are delusions, and highly disorganized speech.
While negative symptoms are typical functions that have been subtracted away. So a severe reduction in motivation, speaking very little, deep social withdrawal or, the flattened emotional expression Bleuler was talking about.
Exactly. And then the third piece is the cognitive domain. And honestly, this is often the most disabling part for a person's daily life.
Really?
Yeah, we're talking about impaired working memory and a breakdown in executive function.
Okay, so let's translate those clinical terms for the listener. What does a breakdown in executive function actually look like for someone trying to go to college or hold a job?
Think of executive function as like the CEO of your brain. It plans, it organizes, and executes tasks. If that breaks down, just figuring out the sequence of steps to cook a meal or prioritizing assignments at work, it becomes incredibly difficult.
Wow.
And working memory is your brain's scratch pad. It's holding a phone number in your head just long enough to dial it. So when that scratch pad keeps getting wiped clean every few seconds, following a complex conversation or reading a textbook becomes a monumental struggle.
That sounds exhausting. And to get a diagnosis today, you need at least 2 of these symptoms persisting for a month, with overall signs lasting 6 months. And crucially, one of those symptoms must be hallucinations, delusions, or disorganized speech.
Right.
The exact things that Bleuler totally sidelined.
It really just shows how much the diagnostic target has moved over the years.
Which brings up the labels we are all so used to hearing, like paranoid schizophrenia or catatonic. The sources say they're just gone now.
Completely eliminated in the 2013 DSM-5 update.
Yeah.
Researchers spent decades tracking patients who had been sorted into those 5 classic subtypes, and what they found was massive diagnostic instability.
Meaning people were shifting between categories.
Constantly. Someone might present with severe paranoia during one episode, but look entirely catatonic a few years later. And worse than that, sorting people into those boxes didn't actually help doctors predict what medication would work or how the illness would progress. The subtypes just weren't based on distinct underlying biology.
This feels like a huge paradigm shift. If it's not these distinct little boxes, what are we actually looking at?
We are looking at a syndrome. It's a final common pathway of overlapping symptoms. Much of the field actually refers to it now as the schizophrenias, plural.
Oh, interesting.
Or a psychosis spectrum. It's likely several different biological pathways that all end up looking similar on the surface.
Well, if it's a spectrum, the immediate question is, what pushes someone onto it in the first place? And the sources point to this massive, entangled web of biology and environment. On the biological side, this is a polygenic disorder.
Right. A 2014 study by the Psychiatric Genomics Consortium identified over 100 distinct genetic loci. So specific locations on our chromosomes associated with schizophrenia risk.
So there isn't just one single schizophrenia gene that you can go get tested for.
Not at all. It's not like Huntington's disease, where a single genetic mutation acts like a simple on-off switch. Each of those 100-plus loci contributes just a tiny fraction of a percent to your overall risk.
Okay.
It's much closer to how you inherit your height or your baseline blood pressure. It's an accumulation of factors.
Classic twin studies show this so clearly. Irving Gottsman's research found that if your identical twin has schizophrenia, your risk is roughly 40 to 50%, which is huge compared to the general population risk, which is under 1%.
It's huge, but that number also holds a pretty profound mystery.
Yeah, because if identical twins share essentially the exact same DNA, shouldn't that number be 100%? Like the missing 50% has to be coming from somewhere else.
And this is where we have to talk about the Genane quadruplets.
This story is wild.
It really is. In 1955, a psychologist at the NIMH, David Rosenthal, studied 4 genetically identical sisters. They were given the pseudonym Genane, which means dire birth, to protect their identity. And all 4 eventually developed schizophrenia.
Which is just an incredibly rare statistical anomaly on top of monozygotic quadruplets already being super rare. You can imagine the initial reaction in the scientific community, like, this looks like absolute proof that your genes dictate your fate.
Right, until they looked closer. The 4 sisters actually had wildly different symptom severities, different ages of onset, and completely different long-term outcomes. And when researchers examined their home life, they found a deeply chaotic, abusive environment.
So they had the exact same genetic blueprint, but the environment interacted with that blueprint in totally different ways for each sister.
Yes. This became the textbook illustration of the diathesis stress model.
Okay, let's build a mental model for that for our listeners. Instead of the old cliches, think of it like engineering a bridge. The genetics, the diathesis, determine the structural load limit of the bridge.
Okay, I'm with you.
Some bridges are built with these invisible microfractures in the concrete, so they're vulnerable. But the bridge doesn't actually collapse unless it's subjected to intense environmental stress, like a hurricane or a massive overload of heavy traffic.
That is a really great way to view it. If the hurricane never hits, the bridge stands. The genetics set the vulnerability, but the environment actually determines the outcome.
But if the microenvironment of one family's house has that much influence, what happens when you look at macro environments,
Okay.
whole societies?
Well, then we get one of the most counterintuitive findings in psychiatric history. In the 1970s, the World Health Organization launched the International Pilot Study of Schizophrenia, and they tracked patients across industrialized nations like the US, UK, Denmark, and developing nations like Nigeria, India, and Colombia.
And naturally, you'd assume the wealthy nations with advanced medical infrastructure and heavily funded hospitals would obviously see the best recovery rates.
The exact opposite happened.
Wow.
Patients in the developing nations actually showed better long-term clinical outcomes and higher rates of full functional recovery.
How is that even possible? Is it just a flaw in the study data, or?
Well, the methodology has definitely been debated heavily, sure, but the mechanism behind the finding is what's really vital. In many of the industrialized nations, the standard of care was heavily custodial, meaning you were diagnosed, removed from your community, and placed in a hospital ward. You just became a patient permanently.
So you were basically stripped of your normal social roles.
Exactly. And in the developing sites, there was often less stigma attached to the symptoms and, crucially, stronger, more integrated family structures. The individual remained part of the communal fabric. They were given roles they could actually manage.
That makes a lot of sense.
And it turns out that social integration acts as a massive protective factor against the cognitive and negative symptoms of the illness. Isolation accelerates decline, whereas community preserves function.
We do need to be really careful here, though, because the definition of environmental causes has a deeply troubled history in psychiatry. I mean, there was a period where the environment was just used as a weapon to blame people.
Oh, absolutely. The most tragic example being the schizophrenogenic mother theory from 1948.
Right. The idea that a cold, rejecting mother literally caused her child's schizophrenia.
It generated decades of agonizing, completely unwarranted guilt for parents before being totally abandoned. High family stress might trigger a relapse in someone who is already ill, but parenting styles do not cause this neurodevelopmental disorder, period.
And the sources also detail how the diagnosis itself has absorbed societal and political anxieties over the years. We see this in the impartial historical reporting from the sources. Like in the Soviet Union, psychiatrists created a diagnosis called sluggish schizophrenia.
Right.
They claimed that political dissent without any hallucinations was an early symptom of a slow-developing psychotic illness. Prominent dissidents, like Vladimir Bukovsky, were forcibly institutionalized under this label.
And in the U.S., during the 1960s and 70s, historian Jonathan Metzl documented how the schizophrenia diagnosis was disproportionately applied to Black men. Hospital case files from that era explicitly link the clinical diagnosis to civil rights era anger and activism.
So the medical label essentially became a container for the culture's political fears.
Yeah.
Which is exactly why understanding the hard science and how it translates to real-world treatment is so critical today.
Yeah, and a massive breakthrough in that hard science happened in the 1950s with the dopamine hypothesis. French researchers, Henri Laborie, Jean Delay, and Pierre Denneker, they were involved in the development of chlorpromazine, which is the first true antipsychotic medication.
Okay.
And it led to the discovery that schizophrenia symptoms were intimately linked to overactive dopamine signaling in certain brain pathways.
But how does dopamine actually cause these symptoms? We usually hear about dopamine as, the reward chemical. Why would that cause hallucinations?
Think of dopamine as the brain's highlighter pen. It tells your brain what is important, what stimuli to actually pay attention to. If you have a flood of dopamine in the wrong areas, your brain starts highlighting totally irrelevant background noise.
Oh, wow.
Yeah, so a random shadow becomes highly significant. A passing thought feels like a voice from outside. It basically disrupts the signal-to-noise ratio.
So these antipsychotic medications, how are they fixing that?
By acting as receptor antagonists, they literally sit in the dopamine receptors in the brain, blocking the excess dopamine from binding. It turns down the volume on that background noise, which is incredibly effective at reducing positive symptoms like delusions.
Which is what finally allowed millions of people to leave asylum wards and return to society. But there's still this massive barrier of public perception today. If you look at pop culture, the media heavily portrays individuals with schizophrenia as inherently violent or unpredictable.
Yeah, but the epidemiological data tells a very different story. The vast majority of people with schizophrenia are never violent. In fact, they are significantly more likely to be the victims of violence.
Right.
The elevated risk we do occasionally see in the data is almost entirely clustered within a specific subset of patients, and those are the ones who have co-occurring untreated substance use disorders.
So it's the substance abuse driving the risk, not the schizophrenia diagnosis on its own.
Precisely. And conflating the two just fuels stigma, which isolates people and delays them from seeking help.
That delay is devastating, especially when you factor in the age of onset. We mentioned earlier that this strikes in the late teens and 20s. If someone is terrified of the stigma, they hide their symptoms during the exact years they should be finishing school or starting a career.
Untreated psychosis interacting with poverty and lack of support is what drives the tragic rates of homelessness and justice system involvement we see today.
And this brings us to a really urgent, modern public health debate: the environmental stressor of our current era, which is cannabis. The sources show numerous studies linking high-potency adolescent cannabis use to an increased risk of psychosis.
This is the diathesis stress model playing out in real time. We have young people whose brains are still developing. If they have that underlying genetic vulnerability, so those microfractures in the bridge we talked about, and they introduce high THC cannabis, it acts as a massive environmental stressor on the brain's dopamine system.
So it can actually be the hurricane that triggers the collapse.
Exactly. As cannabis becomes more widely legalized and its potency increases so dramatically, understanding this biological interaction is crucial for public health education. We aren't just talking about mild paranoia anymore. We're talking about triggering a chronic, lifelong psychiatric syndrome in vulnerable individuals.
But the research also offers a massive message of hope. Psychiatry is moving aggressively toward early intervention, specifically targeting what's called the prodrome phase. What exactly is that window?
The prodrome is the period of time, often months or even a few years, before a person experiences a full psychotic break. It's marked by subtle shifts. Like, a teenager might start withdrawing socially, their grades might suddenly slip, or they might express unusual magical thinking that isn't quite a full delusion yet.
It's the warning signs. It's the bridge groaning under the weight before it actually snaps.
Yeah, exactly. And the U.S. has launched initiatives like RAISE, which stands for Recovery After an Initial Schizophrenia Episode. They've proven that if you catch this early, during the prodrome or right after the first episode, and you surround the person with a coordinated specialty care team, so therapy, low-dose medication, family education, supported employment, you can radically alter their life trajectory.
You basically keep them integrated in their community, much like the WHO study suggested was so protective. We have covered a staggering amount of ground today. We've seen how schizophrenia evolved from Kraepelin's premature dementia and Bleuler's split mind into our modern understanding. It is a highly complex polygenic spectrum disorder. It's intimately tied to environmental stressors, and it requires compassionate, community-based intervention, not fear.
And as we look to the future, the very boundaries of this diagnosis are being challenged. Think back to Emil Kraepelin in 1899, drawing that hard line between schizophrenia and bipolar disorder.
The Kraepelinian dichotomy.
Right. Well, modern large-scale genetic studies are finding massive overlap in the genetic risk factors for both of those conditions. The biological architecture just isn't as distinct as Kraepelin thought. We even have a modern diagnosis called schizoaffective disorder, where a patient meets the diagnostic criteria for schizophrenia, but they also experience severe mood episodes, like mania or deep depression, at the exact same time.
So the lines are completely blurring.
They are.
Yeah.
Which raises an incredible question for the future. Like, how much of our current diagnostic manual is going to become completely obsolete in our lifetime? If we are moving toward a broad psychosis spectrum, how might future treatments be customized to your individual brain wiring rather than relying on a century-old categorical label?
It really makes you wonder. We started today talking about the comfort of an X-ray, the desire for a clean, binary answer, broken or not broken. But maybe the murky waters of human neurodevelopment aren't something we should try to force into an X-ray machine. Recognizing the immense complexity of the mind might be the first real step toward treating it effectively. Yeah. Thank you so much for joining us on this deep dive. Keep questioning, keep learning, and keep viewing the world with a bit more nuance.